Trainers, again, जो आपके trainers होंगे वो मतलब they should be all credible people who should have at least 3 years experience. Most of the time it's a lot more than that. 3 years minimum. Trainers should be performing adequate of themselves so that they are able to. Trainer's job is challenging and technically difficult, as you could all see. And always remember, ERCP is a high-risk procedure. And the trainer should have train the trainer course. हम लोग UK में करते हैं, इधर भी हमने शुरू किए हैं. तो briefly, this was part of my bigger lecture, लेकिन I've really cut it down. So difficult biliary cannulation is defined as more than 5 contacts with the papilla, spending more than 5 minutes spent attempting to cannulate the papilla, more than 1 unintended PD cannulation, and again, most important, especially in the light and context of this course as well, trainer and trainee should have clear rules of engagement. When the trainer says stop, it means stop. ये नहीं कि नहीं जी छोड़ो जी मैं एक और करता हूँ ना, ऐसे नहीं, क्योंकि you are dealing with a live patient and it's a high risk procedure. So you might not realize, but the trainer might realize that he is in danger or he needs to intervene now. So that should be the discipline. There is, whenever we do these training programs, there should be formal assessment tools like the DOPS we use, and Khalid would be very familiar with TSAT. I have no idea what that means, but I think you people use the TSAT, US में. I don't know. I just took that from the literature. It basically just the way we fill our DOPS forms, it highlights your trainee strengths and weaknesses, which is important. One should do it honestly so that you benefit from it. ASG recommend that trainees should have 20% of their procedure are set by TSAT. I don't know what's it, but in UK we do it every 10 ERCPs. At the end of their training program, there is formative assessment and there is summative assessment. Summative assessment is the complete signing off. So that should be done at the end of the procedure, but of their training program, starting before they start independent practice. And it should include review of their DOPS and also on live cases. Summative assessment is normally carried out by 2 independent trainers who are not that person's individual trainers. They should be other assessors outside. And after they pass that program, they should be monitored, they should be mentored for another 6 to 12 months, depending on their abilities. ये different levels हैं, मतलब you come across different levels of training in ERCP. Training steps, जो कि I think this is what this course aspires to. We are not doing any advanced levels. So they should have to do selective cannulation, extraction of stones greater than 10 millimeters, treatment of bile leak after cholecystectomy, successful stenting of an extrahepatic biliary strictures, this is the basic placement stents, needle knife pre-cut sphincterotomy. That should be part of your when you are doing your trainee program. Steps 3 and 4 are obviously advanced training that comes with more. So normally in this type we do not encourage advanced training procedures, or because it's you don't want to practice that at home. Just like when they tell you in these magic tricks or stunts, do not practice this at home. So don't do that at home. Send it to another. Stenting a hilar obstruction, that's obviously a more advanced procedure. It shouldn't be attempted by early trainees or level 1 and 2 endoscopists. Removal of intrahepatic duct stones, they are again challenging procedures. Pancreatic therapy, ampulectomy, retrieval of internally migrated stents is always a pain in the backside. And ERCP in surgically altered anatomy after Billrod 2 or other bariatric procedures. Key performance indicator. What do we expect you to perform when you start independent practice? Selective native papillar cannulation of, this is for the people who have just recently been signed off, greater than 80%. After 1 year, our expectation is that, and there should be a stone clearance of greater than 85%. But after 1 year, we should be able to cannulate more than 90% of cases. Similarly, successful stenting of distal biliary strictures, which is non-higher, in greater than 90% of cases after successful biliary cannulation, and overall post-RCP pancreatitis rate of less than 10%. 10% is very generous. It should be less than 2 to 5%. On completion, prior to independent practice, ESGE recommends that a trainee can evidence a procedure volume of greater than 300 cases, native papillary cannulation of 80%, but 90% after a period of mentored independent practice, complete stone clearance, or just a repetition of that. Okay. Thank you very much. Yeah.
We'll begin transmission shortly.